Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
welcome to another episode of Life in Sirens. Today we're talking about airway obstructions. Airway management is the defining skill in advanced pre-hospital care. Few clinical challenges test providers' composure, knowledge, and technical ability more than a critically obstructed airway. Unlike many medical emergencies, airway obstructions allow little time for indecision. Physiologic deterioration occurs rapidly, clinical margins are narrow, and success depends on preparation, systemic thinking, and procedural competence. Today's episode is focused on clinical decision making when it comes to airway obstructions in our pre-hospital setting. So recognition, management, and standards of excellence.
So we're going to go over understanding airway obstruction. So airway obstruction occurs when airflow through the upper or lower airway becomes partially or completely blocked. So some of the pre-hospital causes that we'll see include foreign body aspiration, vomitus or blood, airway edema, infection, trauma, laryngospasm, and anaphylaxis. The clinical presentation can vary widely, but recognizing severity early is critical. Signs of partial obstruction may include stridor, hoarseness, agitation, and increased work of breathing. Signs of complete obstruction are much more ominous. Their complete inability to speak, silent attempts to cough, cyanosis, rapid loss of consciousness. According to the American Heart Association, severe airway obstruction requires immediate intervention to restore airflow. And the complete obstructions, I think, are the ones that they're normally unresponsive when by the time we get there.
Because how often do you get called for choking?
Mm-hmm.
And it's in fact not this classic American Heart Association, if you will.
Yeah.
Choking.
Yeah,
Like,
a lot of times it is.
they're
Honestly,
talking.
a lot of times it's a food bolus.
Yeah.
Yeah. Choking is one of those calls that either you get there and they are completely fine or they are dead
Yeah.
Yes.
already by the time you
Absolutely.
have made it to the
Perry.
residence.
Yeah, it
Yes.
is. There is rarely an in-between.
Okay, so let's talk about physiology and the crucialness of time management with these patients. So the pathophys of airway obstruction is primarily driven by hypoxia. Again, that's why by the time somebody calls 911 for an actual true choking, by the time we get there, they're usually deteriorated. We all know this, but without effective ventilation, oxygen delivery to the brain decreases, myocardial oxygen demand increases, and bradycardia and cardiac arrest may occur. And this is a pathology that you need to be especially keyed into with pediatric patients, because what is the number one cause of cardiac arrest in pediatrics?
Respiratory arrest.
Correct. So neurologic injury can begin within minutes of inadequate ventilation. This makes airway obstruction one of the most time-sensitive emergencies encountered in EMS practice.
So, like we said, not all of these chokings that we might get dispatched to are true chokings. So let's just move down the list, I guess, up the list from least invasive to most invasive things we can do. So initial management, obviously, we're going to focus on restoring airflow with the least invasive intervention possible. And I think this last update of PALS, the choking management changed.
It did.
Which is good, actually. I like
Yeah.
this. So instead of doing, I guess, straight to when they're unresponsive, you can still do back blows, guys, right? That's what they changed it to. And honestly, The one time I've had a apneic baby thrown at me, like I had to do something on the way, and the only thing that I could do while carrying a floppy baby was back blows.
They also
Absolutely.
changed it to where adults now.
Back
You do
blows.
back blows.
You do
yeah,
back blows, and I
which
need
is
to know
interesting.
who in the AHA tested out those logistics.
Yeah.
in the pre-hospital settings.
Yeah,
specifically.
Specifically.
I
I'm
mean, I
like,
think maybe it's people's first instinct.
yeah, and honestly, normally people do whack them on the back.
Yeah.
Yeah.
I have a question. Did anybody's parents ever say put your hands in there when you were choking? Because that was a thing in my house. And I have met other people who also, their parents have said that. You're choking, and they like lift your hands in the air.
I don't think my parents ever told me that, but I do remember hearing it like somewhere.
Why is that a thing? If anybody knows
I
the
don't
origin of that
know.
wives' tale, please inform us.
Yeah.
That's pretty odd.
Interesting. I've never heard that, but
Yeah, I'm
so
not sure
don't
that
do
would help
that.
much.
It's not absolutely not to help in
Yeah, I
any
think
way.
the only way that it would help is that your arms were out of the way for someone to like then do the Heimlich.
Yeah.
Like, eh.
So obviously for the conscious patient, we want to encourage if they are coughing or like sometimes parents will panic because their kid's coughing and turning red, but like we need them to keep coughing. They're doing the right thing. And a lot of the time in those situations, it's like a small bit of aspiration, not like a true choking or whatever. And then like we said, they have updated the guidelines where you are going to do back blows on pediatric and adult patients initially. And then if, I guess, required, you can do those abdominal thrusts, which
Mhm.
you have to be at least the size of the person. I'm just going to be so for real with you.
It is very
Yeah.
difficult to do the Heimlich on somebody that is bigger than you.
Yes.
Mhm.
It's so hard. And it's also embarrassing.
Oh, yeah. You basically feel like you're their backpack.
Yes, and only large men choke on steak. It's a proven fact.
Oh, yeah. It's never like a sweet little baby granny
No.
that you're like, come here, darling.
No, it's
No.
literally a man who's 6'5" and
Who
300
just,
pounds.
who just came in from like carrying a cow.
Yes. And,
And
you're like, what do you
now-
want me to do?
Yeah, now he's choking on a whole
And maybe
cow.
that's why they went to
Yeah.
back blows,
Maybe.
because like I can hit you harder than I can lift you up from your
Yeah,
correct.
gut.
for sure.
And then obviously if our patient is unconscious, initiate CPR.
Mm-hmm.
Visually inspect your airway. Do not
Just keep bagging.
yeah,
Don't do that.
Don't stick things in their mouth hole that aren't there to get things out. Like, don't put your fingers in there. We don't do that anymore.
Mm-mm.
If there's something obvious in there, yank it out. If you know this person's choking, the history lines up, okay? And they're unresponsive when you get there, just go ahead and get out your McGills
Yep.
and your suction and your laryngoscope because,
You're gonna need it.
and it's so satisfying.
Yeah, and a lot of
So
times,
satisfying.
especially if the timeline lines up and they call early enough, you get there fast enough, you can restore ventilation and mentation after
Mhm.
removing the obstruction
Yeah.
if we're not,
Absolutely.
too far down the tubes. But
Mhm.
we have a supervisor, sweet Justin, that has removed many a thing out of an airway.
It's his flavor.
Mm-hmm.
Mhm.
Yep. And so was it you that pulled the scramp out?
Yeah,
Little
a whole
Yeah,
shrimp.
a whole scramp.
It was like they inhaled the shrimp or something. And I just went in there with my McGills, and it was very nice. It was a
Mhm.
great thing. If you're going to have something stuck in your airway, a whole shrimp is the answer.
Something you can
because-
really latch onto the
Right.
tail of.
Yeah.
Yeah, Justin had to
Yeah.
snatch grapes out of there.
I know,
Yeah.
which
And
was
that
impressive.
sounds tough.
Yeah,
Yeah.
especially if they chomp down on them at all.
Yeah. And then you like feel like if you grab it too hard,
Yeah.
you could just like shoot it down there.
Yeah.
Ooh.
The weirdest thing that I think, or the most difficult thing I've had to remove is banana.
Oh, yeah,
Oh.
that's just a mushy mess.
The decanto even is not quite a match for that.
No, I feel like you,
You
have
need
to
like a
like
spoon.
dilute
Yeah.
it. Yeah. That is a
So-
bronchoscope later on.
Yes,
Yeah, for
absolutely.
sure.
So, and that brings me to my next point is bag valve mask ventilations can be attempted, but if you have obvious signs that this is going to be ineffective or it is ineffective, just go straight to trying to remove that obstruction. Obviously.
So when these basic maneuvers, if they fail, we have to rapidly transition to advanced airway planning. So key considerations include predicted difficulty of visualization, presence of airway contamination, patient anatomy and positioning, availability of suction, backup airway strategy.
And the type of suction you have.
Yes.
I've gone on many calls, like flights, where I get on the ground and they don't have decanto.
Yes. Like if you have a yankour, however you say it, if you have it, you're going to have a really hard time removing an
Yeah.
obstruction.
Absolutely.
You need a large
That's
bore
basically
suction.
for saliva.
Yes. So research in pre-hospital airway management demonstrates that first pass success is associated with improved patient outcomes and reduced complication risks. And I think that we all pretty much understand that first attempt, best attempt.
Absolutely.
So you want to make sure that you have all of your tools that you're going to need, especially if you anticipate this being a difficult airway, which I think it's pretty safe to assume on any choking that you should go ahead and anticipate a difficult
Absolutely.
airway.
We already know there's probably an obstruction.
For sure. So repeated attempts is going to increase your hypoxia risk, your aspiration risk, and procedural failure. So as you move forward with attempt after attempt, there is a great rule that if you're not going to change something about your approach, then a second attempt is really not
Moot.
appropriate. And then it just underscores the importance of preparation and deliberate technique. And so this is not an airway where you just grab your blade as fast as you can without setting anything up and just dive in there. You really need to make sure that you have your McGills, you have all of your suction, you have all of your things that you're going to need before you attempt an intubation on this patient.
Absolutely.
Also, a caveat, but for any first responders, or even if you're first on scene, if you know that this is a choking, be very, very cautious about initially putting in a supraglottic airway.
Yeah.
That's a great point.
I think that's a fantastic point.
Because you could make things a lot worse before you make them better.
Significantly worse. The way that a supraglottic sits, the chance of you fully occluding that airway, if it's partially occluded, or shoving that even further down into their trachea is decently high. So if we can ventilate.
If not, go hunting.
Yes. Prior to ventilating, go in, look and see if you can see anything visually. Like, make sure that you...
If you are not in a position where you can visualize the airway to see if there's any obstruction that you can remove, then do your best to ventilate with a bag valve mask until somebody gets there that can do that.
Mm-hmm.
And there's a good chance if you are completely unable to ventilate for some reason, or you're meeting a lot of resistance with a bag valve mask, just anecdotally, that obstruction is going to be high enough where it is literally obstructing. It's still up high enough where it's obstructing both of your bronchi.
Absolutely.
Yes.
And at that point, think about how a supraglottic works. It is still not, still will not be efficient.
It's just above the
Correct.
obstruction, probably.
Yeah. Mm-hmm.
Okay, so along those notes, let's talk about visualization and airway strategy. So, as we've already said, effective visualization is fundamental to a successful intubation. Keep in mind that these are going to be contaminated airways. These are going to be difficult airways. Be super prepared for food, emesis, foreign body, anything that you think that is going to significantly impact your attempt. Be ready for it, and have all of your tools prior to the attempt. It will be of great value to you to be proficient in like the salad technique, any sort of like aggressive suction technique, optimized patient positioning. This needs to be a situation where you are communicating very effectively with everybody around you. Again, not everybody on this scene might have the same training that you do, and maybe it'll be something that not everybody's on the same page. Somebody might be urging to go to supraglottic airway, for instance. So just keep the communication going, make sure that everybody's on the same page, and then, like with any airway, minimize interruption of any sort of oxygen delivery, because any periods of hypoxia is not good for anybody, but especially these patients. That is their number one problem. Airway adjuncts,
Nasal probably if you want, but it's probably just not going to help that much because of where your obstruction is.
And then we are still here using first attempt, best attempt. So whatever it is that you are comfortable with, direct video to get your visualization to be able to remove any foreign body objects that are in there, do that.
There's just one I wish, man, video is great. I wish I would have had a video for my for that shrimp because
Yeah.
dang, that would have been awesome.
Right.
First of all, could have had pictures.
Yes.
Yeah,
Which would be
coulda had
Like,
it
you're never gonna
recorded.
believe this.
A whole
Right.
script was in there.
That would have been awesome.
Yeah. And you can just, I mean, it is better, guys. I know it's not cheating.
It is not cheating.
Yeah, it's honestly, once you transition to video, and we're looking at a new video scope right now at our service, which is pretty nifty. But once you transition to video, it's a whole different skill set.
Mhm.
Like it is I think in ways it is easier. Obviously, it makes your visualization a lot easier, and it makes the strength required to manipulate an airway a lot better.
Yes.
And so it opens the field for multiple providers to be proficient. But I think that the finesse that comes with the use of video and to be able to still access a difficult airway with it is just a whole different skill set.
Yes, it is a different skill set, and I know we've talked about different types of blades on this show in the past, but like, it doesn't matter too much. But I do recommend having a blade that actually is the same shape as your direct blades. It kind of takes a roadblock out of the way.
Yeah, it really does. The few that we've kind of been looking at and playing around with, they all have ergonomic blades, and
Right.
so
Exactly.
they have like your Mac 3, Miller 3s, like all of it, and then they also have hyperangulated blades.
Yes.
They have like obviously your PEDS blades. Some of them are channeled, some of them are not channeled, but it's kind of cool. Most companies now are making blades that are both channeled and unchanneled, and then all of the different varieties. Because what we found, or like just anecdotally realized, is that when you have a hyperangulated blade on an airway that is not difficult,
Yeah.
it actually complicates your attempt quite a bit.
Mhm.
So choosing the right blade once you move to video is also kind of a skill set that you have to
The
learn.
technique is different.
Mm-hmm.
Yeah.
But that's why I like agree with having them be similar to your direct blades, just because there is some cognitive like roadblock for people when they're like, "Oh, now I have to learn a whole new skill," and it's cheating.
Right, and I think that my biggest harp for video is that the rule is first attempt, best attempt. The rule is not video.
Yeah.
So if you are wildly proficient in intubating with a Miller 4 and you don't miss
Yeah.
and you get that tube in 8 seconds, keep doing what you're doing.
Absolutely.
Right? Like it's good to have more tools in your tool belt, but if your first attempt, if that is your best attempt, is a Miller 4 because that's what you've been doing for 40 years, keep doing that.
But please practice outside of the truck, right?
Yeah, for
Yeah.
sure. And I think that that's kind of what providers miss, is that a lot of
Mhm.
times we address it as like an either or scenario.
Right.
But I think that the rule is first attempt, best attempt. So if that is truly what you are best at, keep doing that.
I feel like video laryngoscopes are a lot of times presented as like, this is such an advancement. This is a 3 lead to a 12 lead, or a 12 lead to a 3 lead. But in reality, video laryngoscope to direct laryngoscope is a new IV catheter that self-occludes. Like, it's a great tool, but it's also something that you have to be proficient in for it to be helpful. You have to get in the vein to be able to use the self-occluding
Yeah.
feature. You know what I mean?
Yes.
Yeah, I think
So
that's a great analogy.
Yeah.
You just secured the tube on a difficult airway. Can you prove it? Intublade can. Built by a combat medic turned ER physician who knows what it's like to be questioned after a tough call. No upfront cost, no capital expenditure, just affordable, single-use blades that connect to the smart devices you already have. Every intubation records automatically and uploads to secure cloud storage on our free app. Capture an airway confirmation photo if you need it, generate a secure link, and then paste it into your patient record. Done. Medical directors get a dashboard that tracks every airway across the agency. First pass success rates, performance by provider, field calls separated from training. No more flying blind on QA. No more he said, she said. Just verified proof of what actually happened. Battery free, always ready. Built by providers, for providers. Intoblade.com, because your mission is clear.
I love it. Guys, I love the Interblade. I use it at my advanced area class.
Yeah.
And it's great, actually. So now that you have intubated the patient, this is kind of, I feel like, we always stop here. We're like, okay, you intubated them, go to the hospital.
Yeah, in every scenario and
That's
anything you
it.
ever talk about,
Yeah.
we're like, and they're intubated.
Scene. So after you intubate, and I have been guilty of this. I can't tell you how many times I've RSI'd someone and air shows up and they're like, did you give them any post-intubation? And I'm like, what do you mean?
Absolutely. You do, like, you're doing 16 other things,
Yeah.
and so you don't realize, like, it's been 10 minutes and that
Yes.
ketamine's probably starting to wear
Yes,
off,
they
but your
need
paralytic's not.
something.
It is my biggest fear of being RSI, like having the ability to RSI, I guess, that I am going to accidentally let the sedation wear off and have somebody paralyzed but fully conscious.
And that is obviously a possibility, but I will say the chances of it happening in our realm are low because the
Yeah.
people who we RSI are just so down bad
Yes.
usually.
Very true. Very true. And that is, like, definitely a peace of mind. But I
Yeah.
am just terrified to be that medic that one day someone's like, I was completely awake.
So airway placement, we just kind of stop. Once we get intubated, we just stop and we're like, go to the hospital. And that's it. So after we secure the airway, we need to focus on some major things. Obviously, confirming placement with waveform capnography.
With what?
Waveform capnography.
Please, God, use waveform
Literally.
capnography.
Notice how
I'm
this
scared of you if you're not using
this beautiful, beautiful woman to the right of me did not just say confirm placement on however which way you
it.
see
Yes.
fit and are the most comfortable with.
It's not about your opinion.
It's about our opinion.
And
It's
we
about the data.
chose waveform
It's about the
capnography.
data. And she said confirm placement with specifically waveform capnography.
Correct.
Moving
That
on.
is the golden standard for real, not just. Also, I'm sorry. Don't use color changing as your gold standard. I know it turns gold, but that is not what they mean by the gold standard.
No.
That's all I've got to say about that.
No, if there's a device that if I blow into it, it changes colors, and then I put it on my patient to see if they blow into it, it changes colors, I don't like it.
That's bizarre. How bizarre.
If the catchphrase has to be if the catchphrase has to be urine, as in the color of urine, as in you are in the airway.
That is piss poor decision making.
Piss poor decision making. Yes. Moving on.
We're on a roll today, guys. Obviously, optimizing ventilation. That means if you need to apply PEEP that is greater than 5, go ahead and do that because you should already have a PEEP valve on your BVM. If you need to place a patient on a ventilator and you have a ventilator, do that. If you need to reposition them, do that. If you need to you have the opportunity to place an OG, please do that. Obviously, focus on ventilation. All these other things are just secondary. And then oxygenation and perfusion.
Yay!
Are they getting enough oxygen? Increase their FiO2. Are they perfusing well? Do we need to add some pressors? Do we need to add some sedation and some pressors? Do we need to just add some sedation? Yes, you need to add sedation. Pain management, something. And then if we have not been able to remove the obstruction, is there even an obstruction that we can remove? Or it is way too deep for us to access in this patient. We need to make sure we're taking them to a facility that can do these emergency, like bronchoscopies and things like that, which I think most general hospitals can do with ICUs. However, do you guys know what size tube you should hope to place so that a bronch can be performed through that tube?
Isn't it above a 7?
An 8.0. I mean, it's barely bigger, but the inside diameter matters
For
for
the scope.
bronch. Yeah. Post-resuscitation physiology. Okay, so you've resuscitated them, hopefully before you decided to put a tube down their throat. But we understand crash airways happen, and sometimes these things are ongoing simultaneously. But it requires a lot of attention. So make sure you are talking to your teammates. You're making sure that everybody has a job. Everyone has a task. I think that's the best thing to do. Assign roles. Even if you are the highest and maybe you're the only paramedic on scene or whatever it is, there are plenty of tasks that can be performed by people who are BLS. Pretty much the only thing that needs to be performed ALS is the intubation. So give everybody a task. Make sure that we have the things prepared. I am always going to make sure I have some kind of resuscitative presser, like some kind of presser ready when I'm deciding to RSI someone if available. You can throw it away. It's cheap.
Yeah.
Epi and norepi, cheap. Okay?
Yeah, just go ahead and get that bad boy mixed up and ready to go.
It's alright if you have to throw it away. And if somebody yells at you for wasting that, is it more wasteful to waste a 250cc bag with epi in it or a whole person?
Oh.
Just wondering.
Dang.
Please approach it exactly as Soph just did. Oh my gosh, quick question. Is it more wasteful to throw away this CC bag, this general CCs, however many you have in there, an epi, or a human being?
It's a great question.
I was going to say, like, offer to buy them a pig or something. So they can harvest their own
They can
epi,
harvest
but...
their own. Maybe we could scare
That
them and
works
harvest
too.
their epi.
Yeah, there we go.
Rah!
There
Give
we
me
go.
that.
Monsters Inc. over here. Sorry guys, we're having fun.
It's the first day that it's nice outside, and I think that
The sun is doing us good.
Yeah.
it's really doing something for us
Y'all
on the
have
inside,
been listening to the wintertime version of us.
which is
We did
really
get a little
just a
sad,
shell.
honestly.
Yeah, it's really hard to tell that we're down bad until it gets light outside again, and then we're like, ugh,
I'm like,
We're
oh my
crackheads.
god, I have
the
a
world is a
personality.
beautiful place.
We're here for you.
So now that we've intubated,
Mm.
we have handled post-resuscitation management.
Mhm.
Let's talk about the standards of clinical excellence, because excellence in airway management is different than some other management of different skills, because it's not just technique alone.
Right.
It has to do with early recognition, structured decision making, effective teamwork, contingency planning, and continuous training.
Have a real contingency plan.
Mm-hmm. And so
Soapbox.
statistically, you have to perform over 10 intubations quarterly to be considered proficient,
It really is not a lot.
right? But if you're at a service where you maybe RSI like once a year, right, and you don't actually get that amount of practice,
Yeah.
then you are not proficient. Most providers are not proficient. So the clinical training, the continuous training, and going and like getting maybe OR days if you can, or even just going and doing intubations with mannequins. Doing the same thing with like your vent management. I know a lot of people have Hamiltons. They have like a vent simulator
Yeah.
app that you can go through different patient presentations and things. The continuous training is really what's going to make a huge difference here. But along the lines of training, you also have to pay attention to planning. So have your backup, have your backups back up, have your backups back up, have a person that backs up all of that. Like,
yeah, and make sure that
Mhm.
you get your crank kit out. We talked about this.
yeah. And ideally, you need none of that. But you want to
Ward
make
off the
sure.
evil spirits.
Yeah, you want to. The EMS gods are tricky little bastards. So if you do not have any of those things out, you'll need them.
You will.
Yep.
100%.
And so as long as you have a few plans for if things go poorly, you will be
Absolutely.
prepared for the next step every time.
And you know what is such an oversight, and I've failed to do this before, and now I make it a habit. Put the pads on your patient if you're RSIing them.
Bro, yes.
Mm-hmm.
This
I-
is serious.
It's a big oversight.
It
I-
is.
I have made that mistake so many times.
Yeah.
Like to the most of the point, I'm already mixing meds by the time Aubrey's like getting out pads and is putting them on
Yeah.
somebody. And I'll
Just-
turn and look and be like, did something happen? She's like,
The vibes are off.
no, you're just about to RSI them, so I figured this would be fun
Exactly.
to have.
You never know.
Yeah.
You never knew.
About to
So we talked about like simulation-based education. It improves your airway success rates and provider confidence. That muscle memory is super, super important. So practice. Get your mannequins out. I don't know if you got a friend with no gag reflex. See how that goes.
I mean, I've seen things happen.
I've seen the videos. I've seen the
'em.
TikToks.
I know about
Y'all
it.
are out there.
So high reliability EMS systems emphasize deliberate airway algorithms and performance review. Every RSI gets reviewed. Every intubation gets reviewed. You want to have a plan. You want to have a plan for QA. You want to have a plan for your actual procedure.
Do chart
plans-
reviews, guys.
Yeah, plans
fun.
help you stay on track, and reviewing charts and going through like what has happened helps you be a better provider in the future.
Yes, and it's not as hard as we try to make it. Just
No.
remove the details.
Yeah. I feel like on this show say a lot of like one-liners of what EMS is in like one sentence, and I think that it's so funny because EMS in and of itself, the literal profession, is a contingency plan. That's nobody, well, okay, with a caveat of a few people. It's nobody's like plan. I'm going to wake up today and I'm going to call 911. Like EMS in and of itself is a contingency plan, and everything that we do also involves a contingency plan. So it's kind of, ironic to think that one of the biggest procedures that we are in charge of, that you would not
Do all the things.
do that with that mindset.
Yeah. I also think that it's funny that most providers are here because this was their contingency plan.
Yes.
Like a lot of people that landed in EMS
That's
landed
so
here
true.
on accident and stayed because they loved it.
Yeah.
But it was not the plan.
No. Nobody grows up to be like, I'm going to be a paramedic.
Right.
Which is
Maybe
so
now they
funny.
will. I don't
Maybe,
know. But in
yeah.
our day, absolutely not.
No,
No.
I didn't even know this was an option.
No, neither. I was like, if I want to do medicine, it must be in building.
Literally.
Turns
Mhm.
out,
I
Go to
was like-
school for fine arts.
I was like, oh, I'm sorry. I get to run these screets?
Yeah.
Absolutely.
You have no idea what you've gotten yourself into.
Yeah, I was like, I will study biology and work in a lab.
At least that was close, right?
yeah, it's
Adjacent.
close-ish. Yeah. Okay, this has been an eventful episode. Let's close her out. Guys, airway obstruction is a reminder that EMS remains a profession grounded in decisive action. When oxygen delivery fails, the provider becomes the intervention. Preparation, competence, and composure are not optional. They are the foundation of patient survival.
So thank you for joining us for this very eventful Life in Sirens clinical episode, and we will have that mini episode out soon, where we rant about succinylcholine and rocuronium, which is way too fun.
Listen to us crash out in real time.
real big crash out. It's
Listener
fine.
discretion is advised.
It's an evidence-based crash out. Okay.
Ooh.
Ooh. I'd be liking that. We're making a shirt.
Put that on a t-shirt.
Put
Yep.
it on a t-shirt.
Evidence-based crash out.
See it in our merch soon.
Write that down.
All right, yeah, hang on.
Text that in the group.
Yeah, put that here. I got it. I got my phone.
All right. Anyway, see you guys on the next one. Got a blast. If this episode brought you value, take a moment to rate and review the show. It helps more providers find us. Follow Life in Sirens, join our mailing list for exclusive content, and visit lifeinsirenspodcast.com for resources and downloadables built for the modern provider. And if this conversation made you think, send it to your partner, your preceptee, or someone on your crew, because better providers build better systems.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.